Thank you very much and good morning. I'm also extremely happy that I'm able to present the results of the ALIVE-2 trial for you today and for everyone tomorrow. This trial investigated low molecular weight heparin and standard pregnancy care versus standard pregnancy care alone for women with recurrent miscarriage and inherited forms of thrombophilia. We have previously shown that in unexplained recurrent miscarriage, antithrombotic therapy with low molecular weight heparin or aspirin does not help. In women with thrombophilia in that trial, however, we noticed a relative risk of 1.31, so 30% more chances of having a live birth in the very small subgroup of women with inherited thrombophilia that were included in that study. So we then designed the ALIVE-2 study, which is a multi-center study with the inclusion criteria listed here. Women had to have had 2 or more miscarriages, confirmed inherited thrombophilia. These are factor V Leiden, prothrombin mutation, or a deficiency of antithrombin, protein C, or protein S. And they had to be randomized and started treatment prior to 7 weeks of gestational age. We had 2 coordinating centers in Amsterdam and in Warwick, UK. And we randomized, as said, towards low molecular weight heparin or no low molecular weight heparin. The primary outcome was live birth, and safety outcomes were obvious for a study in pregnant women with an anticoagulant. After screening more than 10,000 women over a period of 9 years, we were able to register more than 400 women and to randomize 326. And you can see the baseline characteristics here. Approximately 70% of the women had 3 or more miscarriages, and you can see, as expected, that the majority had factor V Leiden, heterozygous, or prothrombin mutation, but we also had women with the more severe thrombophilias or combined thrombophilias included. I'm now getting to the primary endpoint, and of course we hypothesized that due to blood clotting or other effects of thrombophilia, we would increase the live birth. That was the hypothesis of the study. But what we observed was a 71% live birth, as you can see in this graph, with an absolute difference of 0.7%, and the confidence intervals shown between -9% and 10%, meaning that we cannot exclude a 10% difference in either direction. The odds ratios also adjusted for major variations in baseline characteristics did also not show an increase in live birth rate by the intervention with low molecular weight heparin. What we did observe, however, was a difference in side effects, in adverse events. I'm showing the overall numbers, the proportion of women who reported 1 or more side effects or adverse events here. And the differences was explained by minor side effects, but very annoying side effects for women who have to inject themselves for the entire pregnancy. Easy bruising, skin reactions at injection sites, and minor bleeding. And this difference was statistically significant. So the conclusions and take-home messages, I think, are pretty clear, and I'm very pleased that we, in my view at least, have ended a debate of decades. In pregnant women with inherited thrombophilia and recurrent miscarriage, the live birth rate is approximately 70% with standard pregnancy care. And I think this is also important. We should not say this is a negative study, but what we can do in our offices, in our practices, is reassure women with a history of recurrent pregnancy loss that they have 70% chances of having a healthy baby at the end of the day in their next pregnancy. Low molecular weight heparin, however, does not increase this live birth rate. And therefore, following up from this, we should not treat women with low molecular weight heparin to prevent miscarriage, and even more so, we shouldn't test them for inherited thrombophilia for this indication. And therefore, the impact, I think, can be pretty large. We can avoid low molecular weight heparin during pregnancy. This will lower the burden of treatment, and cost savings, and this is just rough, very rough estimates, are approximately $3,500 for the US for the entire pregnancy. But even more so, if we avoid thrombophilia testing in this entire group, for every identified patient, and I think these are conservative estimates, we would save another $4,000. And finally, but not least, I am extremely proud that on behalf of all my collaborators, we can state that thromboprophylaxis randomized controlled trials in pregnancy can and must be done. And I'm doing this on behalf of the ALIVE-2 investigators, but also would like to draw your attention to the high-low study that we published earlier this year. Thank you for your attention.